Session of Anatomical and Surgical Consideration of Facial Reanimation by Dr. Deepak Balin, sir. He needs no introduction. He's a professor from Muta Institute. He's one of my mentor also. So I think with this small intro, we'll start with the meeting, sir.
Yeah. Thanks, Bhargav, and
Thank you,
good
sir.
morning to everyone who's here. So this year at FHNO, I had to give a talk on facial reanimation. Unfortunately, it was only for about 15 minutes, and I had a huge presentation. So I wasn't able to uh, present all the slides slowly and clearly. So I had a talk with Bhargav, and we decided that we will uh, make this a three-part uh, presentation or three-part discussion. So the first, which is today, is going to be the introduction to facial reanimation. What are the considerations? What do you have to look for in the patient? And what are the options that are available to us? The second talk would be on static and dynamic procedures. Uh, I will be sharing some videos on that, and the videos will be put up on YouTube as well. And the third lecture would be on free functioning muscle transfer and other ancillary procedures. So those videos also will be put up on YouTube after the meeting. So these are the topics that I'm going to cover. Diagnosing a facial palsy which needs intervention. Not all facial palsies need intervention. There are a few criteria that we have to adopt before we decide which patient needs intervention. What are the anatomical considerations in approaching facial palsy? This has a lot to do with what nerves you've got to work with, what muscles you've got to work with, what substitutions you need to do, and things like that. Is there any role for diagnostic tests in a facial reanimation? You know that facial reanimation is done after a minimum of 12 months of the facial palsy when no function returns. And none of these diagnostic tests that we use, that is ENOG or EMG, has been routinely used. So we'll find out what are the current indications for those two tests. What are the donor and recipient nerves that we use for facial reanimation? How do you grade facial palsy? And how do you plan the interventions? So if you want the definition of facial palsy and reanimation, facial reanimation is used to recreate apparent lifelike movement of the facial muscle. And there are various dynamic and static procedures that are available. So before we go into defining what reanimation is, we have to understand certain terminologies. So facial palsy is the term encompassing the entire spectrum of facial movement disorders. Facial paralysis is complete absence of facial movement and loss of tone of facial muscles. Flaccid facial palsy is weakness of the muscle tone also, along with facial weakness. And this is bad because the muscles have lost their neuromuscular junctions and their ability to contract. And for these, you have to do slightly different techniques to rehabilitate such patients. Non-flaccid facial palsy is when there has been some nerve regeneration. There is facial palsy, but the nerve muscle tone is still maintained, and you might have varying degrees of synkinesis. And facial synkinesis is when there is a group of muscles acting either during volitional movement or spontaneous expression. And this can be one of the side effects of facial reanimation. So we should be very clear and careful when we try to reanimate the muscles after facial palsy. Now, before we go into the details, a brief few slides on the anatomy of the facial nerve. If you look at the extratemporal course of the facial nerve through cadaveric studies, it was found way back in 1956 that there are 6 types of facial nerve branching. Now, the importance of this facial nerve branching is that when you select a distal sectioned nerve, that is a nerve closer to the muscles, they can be from different origins. So it is always prudent to dissect the muscle or dissect the nerve stumps all the way to the muscle to identify that the correct muscle is being reinnervated. And if you look at type 4, there's a lot of interconnections between the buccal branches as well as the eye branches. So these patients generally, even if sectioning of one of the nerves, because of the cross innervation, they tend to do better than other people. But the commonest type is the type 3, which is about 28%. Now, not all the branches of the nerve lie in the same plane on the face. As you see closer to the exit point from the stylomastoid foramen, the nerve is quite deep. Then the different branches of the nerves are in different levels. For example, if you look at the frontalis muscle, the nerve lies under the frontalis. If you look at the nerve going to the eye, it is below the SMAS layer. If you look at the nerve going as a buccal branch, it also is again under the SMAS layer, but above the buccinator and buccal pad of fat. And if you look at the marginal, it is under the platysma muscle. Now, why this is important is if you want to preserve the distal stumps of the facial nerve, you should know which plane to dissect and find the nerve. The commonest that we try to find are the eye branches, which are under the SMAS, and the platysma and the marginal, which is under the platysma muscle. So these are the two nerves that we try to commonly delineate to neurotize. So these are the different planes that the nerves exist. Now, if you look at the muscles of the face, you have the scalp muscles, eyelid muscles, nose muscles, and muscles of the mouth. Now, if you look at the muscles of the mouth, there are several muscles which have varying actions. But during facial reanimation, if you're able to do a nerve to nerve coaptation, these muscles might retain or regain their individual functions. Otherwise, when we are doing a functioning muscle transfer or a static sling, you only treat the angle of mouth in one vector. You can't recreate the individual muscles, their movements. But in the muscles of the eye, if you can recreate the orbicularis oculi muscle function, that should be enough. And usually it's a single nerve going to these muscles, and you'll be able to get a good functional results. The muscles of the nose usually are important because they cause collapse of the ala. So these can be reconstructed with a static sling. So remember, eye, one muscle is sufficient to regain eye function. Angle of mouth, it's usually just the angle of mouth as a vector or as a single point which is being elevated, not the individual muscles. And the muscles of the nose are usually uh, treated with uh, are usually treated with a static sling. Now, sometimes we need to follow anatomical landmarks to identify the distal facial nerve branches. So these are the landmarks for the frontal, the zygomatic or the buccal, and the marginal mandibular nerve. These are important in case you need to corroborate your intraoperative findings with the surface marking. But always use a nerve stimulator to stimulate the distal cut margins to see which muscles are being activated. So, diagnosing a facial palsy that requires correction, we have to look at the forehead, eye, midface, and angle of mouth and grade the paralysis. We have to find out what the duration of the facial palsy and its progression. We need to know what prior procedure was done. We need to know the prior history of facial nerve status, if documented, whether the patient has a single vector or multi-vector disability, and what are the symptoms of the patient. Now, the important thing here is the duration is important. I will tell you why as we go along. The prior procedure done is very important. If the patient has had a parotidectomy, you know it's the extratemporal facial nerve that has the injury. If the patient has had a mastoidectomy, you know it's the mastoid segment or the intratympanic segment that may be at risk. If the patient has had a cerebropontine angle tumor resection, you know that the transaction is much, much higher. So, and in those cases, there'll be no driver nerve for you to co-opt the facial nerve to its branches. And of course, in a CP angle tumor, there'll be no transection of the extratemporal facial nerve. So, and we also need to know if the prior facial nerve was left intact at the end of the procedure, because that has some meaning in when you intervene. These are some of the problems that the patient has. Eye irritation, epiphora. There can be ptosis of the brow because of the frontalis not working. There can be speech difficulties, drooling, and there can be nasal obstruction. Now, what are the factors in decision making? The first and most important thing for us to ascertain is that there is no return of facial function. So we need to know and we need to be sure that the facial function is not going to return. You also need to know the status of the end plates of the muscle. So if the muscle is denervated or dead, there is no point trying to innervate the muscles of the paralyzed side by neurotizing the muscles. What are the alternate nerves that we can have as drivers? So the alternate nerves can be the trigeminal nerve, that is the mesenteric nerve, or it can be a cross space nerve graft. And we should also be ready to go to the normal side to get a driver nerve. And we also have to move beyond the eye and the angle of mouth for rehabilitation, which we will see in the third lecture. And eye reanimation can always be done earlier than the rest of the face because eye rehabilitation is separate from the rest of the face. So if you look at muscle denervation, I told you one of the important factors is the status of the end plate of the muscle. So if you look at muscle denervation, once the nerve is damaged, the fiber size of the nerve and the muscle decrease to half size in 2 weeks. And if there is long-term denervation, that is 18 to 24 months post-injury, this is where electrodiagnostic testing has some role. There will be silence on the EMG, or if you take a biopsy from the muscle, it will show fibrosis atrophy. Now, silent EMG and fibrosis atrophy of the muscles preclude any sort of reanimating the in situ muscles on that side, simply because the muscles won't work. And also remember, facial nerve regenerates at approximately 1 millimeter a day. So if your facial nerve damage is distal, closer to the muscle, recovery is quicker, even if you use the nerve graft. But if you have a very proximal damage, like at the cerebropontine angle, it takes about 18 months to recover. So what are the anatomical considerations? So the immediate consideration, let's say you're doing a parotidectomy and you have to sacrifice, let's say a couple of scenarios. You have to sacrifice a section of the nerve. Now, your proximal facial nerve stump is intact and your distal branches are all intact. Now, if you try to connect the proximal branch of the facial nerve via a split nerve graft to all the distal branches of the facial nerve, the patient will have very bad synkinesis. So neurotization. So if you have a proximal facial nerve, I would only do the midface and the lower face. I would do the eye as a separate procedure with a temporalis transfer or a gold weight or something like that. But I would never do facial trunk simultaneously to all the distal branches. Let's say your nerve has been transected beyond the divisions of the facial nerve. Then you can selectively neurotize the distal branches by putting nerve grafts, and you can get good function, good mimetic function without much synkinesis. If you don't have any proximal facial nerve, but you have the trunk of the facial nerve in the extratemporal course for a variable distance, even that drilling the mastoid and getting a proximal stump and putting a nerve graft will still result in synkinesis. So the best outcome for this is using, a facial nerve which has two divisions and then coapting it to the rest of the distal nerves, or just coapting to the lower division. Now, as I mentioned, the neuromuscular junction depends on totally on time. If it is 12 months to 18 months, we can still think of it after doing EMG and biopsies. But if that is not possible, we have to think of doing a free functioning muscle transfer. Now, the donor nerves, I mentioned about the facial nerve, but we have other nerves like the mesenteric nerve and hypoglossal nerve. Again, both of these I would reserve for the mid and lower face, and I would not use it for the eye. That is why I said eye versus rest of distribution. Now, this can be a single stage procedure versus two staged. So, a single stage, this is in context of a free functioning muscle transfer. So a single stage free functioning muscle transfer, like the gracilis muscle, you can take the gracilis muscle from the thigh, you can fix it between the angle of mouth and the temporoparietal fascia. You can connect the obturator nerve either to the ipsilateral mesenteric or hypoglossal or a cross-face nerve graft and let the muscle be. Or you do in the first stage a cross-face nerve graft, let the nerve grow, and then at a second stage, you can go and put the gracilis muscle. And then there is static versus dynamic, which we will discuss in the subsequent lectures. So I mentioned the driver nerves are the hypoglossal nerve and the mesenteric nerve. These are nerve substitutions, meaning that the patient has to do a couple of exercises following the substitution, and the cerebral plasticity will make it an automatic movement after some point of time. Cross face is from the opposite side facial nerve buccal branch. That gives the best mimetic action, but it takes some time for it to grow and come back to this side of the nerve, this side of the face. And you'll need a long nerve graft like the sural nerve to help you with this cross face anastomosis. There are people who have used the spinal accessory nerve also, but the functional results are bad. But you have to realize that if you take the hypoglossal nerve, the patient always has a risk of developing hypoglossal palsy. So I wouldn't recommend a hypoglossal transfer in old patients, patients who have movement or swallowing disorders, and patients who have lower cranial nerve palsy. Mesenteric nerve is very good, and that is what I would recommend for all patients. And as I mentioned, selective neurotization, identify the distal branches properly, use a nerve graft. The nerve graft should be supple. It should be at least 0.5 to 1 centimeter supple to account for contraction and facial movements. And you avoid using nerve substitutions for eye and the lower face together to avoid synkinesis. So these are the ways that the hypoglossal can be anastomosed to the facial. You have a full hypoglossal, you have a split hypoglossal, you have a split hypoglossal, which is direct. The first split hypoglossal is a jump, and the last is the mesenteric nerve. We will discuss all this in detail in the subsequent slides, in the subsequent lectures. Now, what are the donor nerves that are available for cable graft? So the greater auricular is available, supraclavicular, medial antebrachial cutaneous, lateral antebrachial cutaneous, they are from the forearm, the saphenous from the leg, and the sural nerve, of which the sural nerve has got the largest length. But be careful, sural nerve supplies the sensory input to the lateral foot and the sole. So if the patient's got a diabetic foot or a neuropathic foot, try to avoid the sural nerve. Otherwise, they will have trauma and they would not recognize it. Now, what are the electrodiagnostic tests that they've used for facial nerve function? There are several. That is the nerve excitability, maximal stimulation test, electroneuronography, needle electromyography. So, amongst this, ENG is useful if you're doing testing until 21 days. And this is when the nerve is intact, but there is post-op paralysis. So there is a way of quantifying the ENOG response, but that is not useful for our facial reanimation. So what is useful for our facial reanimation is the electromyography. And as I said, if the patient is having zero potential, you don't have to stimulate the nerve like an ENOG. It is volitional and spontaneous muscle activity, which is measured. If the patient has zero value at 24 months, it means that the muscles have no more functional viability. So this is again another slide showing the prognosticating factors of ENOG and EMG. And you know, there are several scoring systems for facial palsy: House-Brackman, Sunnybrook, Sydney Facial Grading System, Fish, Nottingham, Bajaj Luthra, Neely, and the most recent, the electronic scoring system called eFace. Now, this is the House-Brackman facial nerve grading system. Many of you would know what this is. And 1 is normal and 6 is total paralysis. And we can use this to grade the improvement that we observe following facial reanimation. So when are we actually dependent on electrodiagnostic tests? So when you have the nerve in continuity with postoperative palsy, when you have repaired the nerve to see for return of function and to decide whether further reanimation has to be done or the nerve function will recover. So these are the only 3 indications for using electrodiagnostic testing in the context of facial reanimation. So what is decision making to intervene? So this is a time-bound decision. If no primary repair or substitution has been done or not possible, for example, patient had a bad tumor, patient has no proximal or distal cut ends, there is no way to neurotize the muscle, none of these are possible, then you think of primary reanimation at the time of removal of the tumor itself. But if some primary procedure has been done, like for example, a nerve graft or any other procedure has been done, then you wait for 9 to 12 months at the earliest, or even up to 18 months for return of function. Remember, this is only if a nerve repair has been done and not for other types of reanimation. So if you get a patient referred to you with facial palsy, and there is documentation that the nerve has been cut, you have to go repair it within 30 days of the injury to get maximum return of function. Again, whatever I mentioned to you about whether you do the stump to all 5 branches, stump or the division to selective branches or the stump to lower divisions, all that holds good even in this context. But it has to be done within 30 days of the injury. So eye, midface, and lip are 3 distinct entities. You have to have 3 separate plans. Eye can be reanimated earlier, and age is to be a factor. The reason being, young children, they tolerate facial palsy better because they have better skin tone, better muscle tone. They have a lot of subcutaneous fat, which does not allow for the face to sag. Whereas in old patients with thin skin, they develop ectropion and watering of the eye earlier. They have sagging and drooping of the face. So they might want a quicker facial reanimation than in younger patients. Now, how do you treat the ocular sequelae of facial palsy? So these are the stages that you do. So initially you give supportive care. Uh, you try a tarsography that can be temporary or permanent. If that doesn't work, you want to plan a facial reanimation, which have a lot of options. The important thing is in old people, you have to correct the lower lid ectropion also. So that is done by a canthoplasty and canthopexy. You can do a passive upper eyelid animation with gold weight. You can do a dynamic eyelid animation with temporalis transfer. And the soft tissue repositioning is not done very commonly. And if you look at the lower division of the lower segments of the face, it's all time bound. It's 12 to 24 months. Still, some people think of nerve repair and nerve graft and jumps, but that is only from 12 to 24 months. If it is more than 24 months, you have to think of doing a free functioning muscle transfer. If it is less than 10 to 12 months or less than a year, you can follow the same principles of nerve graft. But this is if you know the electromyographic status of the muscle and it's viable, you can do all of these things. But if it's non-viable, you straight away go and start doing a free functioning muscle transfer. So these are the broad classification: facial nerve repair, cranial nerve substitutions, muscle transpositions or transplants. These include local muscles as well as gracilis, which is a free muscle. There are many ways to suspend the midface, especially the nose. The eyes, again, with static or dynamic techniques. And there are other procedures which we will see in the last presentation in this series. So how do you classify your results? So for grade 1 is superb results, where some mimetic motion is there. Patients can move individual sides of the face. There is complete eye closure. Excellent results are mimetic movement is absent, but other things are seen as in grade 1. In grade 3 is mass movement is present and eye closure is present, and asymmetrical smile is voluntarily possible with maximal effort. Fair is incomplete eye closure and weak mouth. Poor is there's only symmetry, but tone is intact. And type 6 or grade 6 is failure with flaccid musculature and tone is also lost. Now, when you're coming to smile reanimation, hello, hello,
Sir,
can you hear me?
surely. Yes, sir.
Yeah. So
Yes, sir.
the last thing that you have to remember is there is something called smile vector assessment. So this is how you would reanimate the affected site. So one of them is the zygomaticus smile. This is a type of a zygomaticus smile. The second smile is the canine smile. And the third smile is the full denture smile. So based on these three different smiles on the normal side, we have to reanimate the opposite side. So we will discuss this in the subsequent presentations. So if you have facial palsy, which is permanent, then you think of nerve substitution, manage the eye separately and do a functional nerve transfer. Nerve substitution can be mesenteric nerve, and you can combine mesenteric nerve with gold weight or temporalis for the eye. If it is temporary, if the Bell's phenomenon is adequate, do nothing or add a gold weight. If it's long-term palsy for the upper face, I would do a temporalis transfer. If it's lower face, I would do mesenteric or temporalis transfer or free muscle transfer powered by the mesenteric nerve or cross-face nerve. And I would use static slings for the nose and the ala. So in conclusion, reanimation is time-bound. Separate the eye and the lower face, and integrity of the driver nerve and the neuromuscular junction must be ascertained before we proceed with any sort of reanimation. So this is just a basic introduction to how we see, how we plan, when we plan, what are the principles of treatment. The next week, we will talk about all the static and dynamic techniques in detail with surgical videos. and the last talk will be on free functioning muscle transfer. Yeah. Any questions?
Thank you, sir. Thank you so much for the speech. I request everyone to either put them questions in the chat so that we can put them directly to sir.
Sir, can I ask a question, please?
Yes.
Sir, identifying the SMAS can be a challenge. I just want your comments on that, sir.
No, identifying smash where? You mean preauricularly or
Preauricular, sir. Preauricular, sir.
preaurically it is just below the dermis. So I will show
Okay.
you a video of the smash flap. There is something called the smash flap for contour correction. So what you have to do is you have to make the incision on the skin subcutaneous. Use a single skin hook and hold up the dermis there. Okay. And then using a scissors, you dissect between the dermal fat and the underlying tissue. You will get a very tough layer called this, that is a smash layer. So it's very easy to identify it preaurically. I'll show you some photos and videos. And it's very good because you can suture it directly to the preauricular cartilage. And that gives you a very nice contour correction in these sections.
Thank you very much, sir.
Yeah.
So
Somebody
Dr.
else
Aditya,
asked that question.
yeah,
Yeah.
Dr. Aditya was asking how to manage a case with long-term facial palsy and facial muscle atrophy.
So in those cases, we have to look at the eye and the angle of mouth separately. For the angle of mouth, you have to put a different muscle there to mimic the movements of the angle of mouth. And that is the free functioning muscle transfer, which is the gracilis muscle. There are other muscles also available like pectoralis minor and other things. We will discuss that in the third week. I'll show you the harvest of a, you need to do microvascular anastomosis and nerve anastomosis and all that. But I'll show you a video of how to harvest the gracilis, how to fix the gracilis and the microvascular anastomosis. There's a technique of putting an unstretched muscle. There's a technique of checking muscle contraction and everything. So in atrophic neuromuscular junction, this is for angle of mouth. For eye, I would simply do a temporalis transfer and come out.
So Dr. Yusuf is asking, will a post-op radiation affects immediate anastomosis?
So there's one very good study done from UK which showed that if you have post-op radiation, the recovery is delayed by 8 to 12 months. It is delayed by 8 to 12 months.
Okay, sir. Dr. Shi is asking, so would you be the what would be the management if the person is getting facial now for 3 consecutive years and with each attack per year paralysis grade is worsening?
You mean in Bell's or what
I
is the
think it's
etiology of the paresis? Or is it zoster reactivation? What is the etiology of the paresis?
most likely it would be, I think, Bell's, so she's not mentioned. Zoster reactivation, that's what.
So in
It's,
those cases, there is really no surgical management. The only management is if you go on Google, you'll find a lot of exercises. There are three things. There is electrostimulation, there is facial palsy exercises for bells, and there is laser stimulation. These should be tried for cases who are not candidates for Bell's palsy, candidates for facial reanimation in Bell's palsy. So I don't think any surgical intervention would help uh, with this problem.
okay, sir. Dr.
I
Chaudhary
can't
was
see the
just,
question.
there is a chat button in the lower part, right lower part.
Chat.
Yeah. From a question from Dr. Vijay Ramaswamy, sir. Do you do a mastectomy if main facial trunk or facial nerve is involved by tumor intraop?
So you mean to say that you have sectioned the distal facial nerve and you found no proximal stump, so you drilled into the mastoid to get a trunk. That is the
Yes, sir.
question, correct?
Yeah, I think so,
But
sir.
the
Yes, sir.
problem is if you do that anastomosis from there to the distal connection, it will be total synkinesis because there is no topographical arrangement of nerves within the facial nerve. So I have had such cases where people have tried doing from the mastoid till the extratemporal course of the facial nerve trunk. They have tried to do main trunk to main trunk anastomosis using a nerve graft, had bad synkinesis, and then I went and Botoxed all the unnecessary nerves that was causing the synkinesis. And the one that I have done from the mastoid is I have selectively only reinnervated the lower face and the mid face, and for the eye, I just put a temporalis transfer. Temporalis transfer is a very easy procedure. It takes 20-30 minutes to do. It's a very elegant procedure. But I will never co-opt trunk to trunk for fear of synkinesis. And that
Okay.
synkinesis sometimes is very difficult to correct also.
Okay, sir. Sir, I have a question, sir. Recently,
Yes,
I
please.
did a CA parotid. The whole nerve is completely engulfed by the tumor. Luckily,
Yes.
I happened to have a facial nerve monitor at that time. So
Mm-hmm.
the trunk part which is engulfed uh, is is not passing current. I mean,
Mm-hmm.
later on when I dissected it above and below, the
Mm-hmm.
probe when I touched the probe above and below the engulfment, I could feel the nerve is showing that there is function. But in
Mm-hmm.
the junction where the engulfment is there, I was not able to uh, get the response from the nerve monitor. So does this
Okay.
often happen, or is it
Yeah.
an
It's a
sir?
very common
So
occurrence.
so my primary question then was, sir, how deep should I shave off? I was little scared to shave off too deep because I may damage the
No,
nerve.
there's no question of
So,
shaving off. You take this nerve will eventually die. You remember
uh,
that. If you leave disease back on that nerve
okay,
will
sir.
eventually get engulfed by the tumor and the patient will have facial palsy. That is
Okay,
an
sir.
inevitable outcome. So in those cases, cut a very small segment, put greater auricular and come out. His nerve function will recover very well.
Okay, sir.
Leaving behind any nerve, it's going to have, you know, it's going to get killed anyway. So uh, just cut it off and put a nerve graft and come on.
Okay, sir. Sir, if at
Someone
all, if
asked
I
me,
do the
do I have a,
procedure,
somebody asked me, do I have a YouTube channel? Yes, it's called Learn Head Neck Surgery. LEARN Head Neck Surgery. All one word. So you can, all my videos are there. Yeah. What was it, Bhargav, you were asking?
sir, if I do that nerve transfer, how many days should
Hmm.
I tell the patient to expect recovery, sir? Just for
From
order
nerve to
purpose.
masseter hypoglossal, you mean? Or
No, sir.
primary
The great
neuropathy, you mean?
auricular now the segment, if I
12
replace
months.
it with,
12 months.
thank you, sir.
And that again depends on the length of the graph that you're using. If
Okay,
it's a
sir.
short graph, it recovers at 1 millimeter a day. So short graphs recover faster than long graphs.
Okay, sir.
So we'll discuss the nerve suturing techniques and all. I'll show you a video. Nerve suturing techniques, how to apply tissue glue, how to position the nerve. All those things I will show next week in the video section.
Yes, sir. Any more questions from the audience, please? I think that's all, sir. No more questions
Yeah,
coming up.
yeah.
So,
Okay, Bhargav, thank you so much.
yeah, thank you, sir. So we'll put
Thank you
up
so much.
the second seminar in the groups. So, yeah, please.
When is the next microvascular workshop? It is in February, March. I'll put up the date. It's not only microvascular, there'll be flap harvest also. Any YouTube channel recommended? I don't think there are too many head neck YouTube channels. You can check my channel for any videos that you like. I'll just type out the name of the channel. It's very simple. Learn head neck surgery. This is the name of the channel. But I don't know if there's any other dedicated head and neck channel showing videos and all that. Yeah, Bhargav will upload this video on his channel, or I can upload this video on my channel. That shouldn't be any
Sir,
congress you recommend for my any
I have put up
congress
your
that you recommend.
link, sir.
Thanks, Bhargav. Any congress you would recommend for microvascular head and neck? See, congresses are all lectures. You have to do it. You have to practice on the rat, or you have to practice under the microscope. So I will let you know if something interesting comes up, and you need at least a week's course. The course should be at least 5 to 7 days. That's what the Amrita course is. You have 5 days of microvascular, 1 day of flap harvest, and 1 day of visiting the theater. So I think doing a 5 to 7 day course is better than just doing a 1 day course. Yeah.
Yes, sir.
Okay, so I'll see all of you next week.
Okay. Thank you, sir.
Yeah, thanks, Barbara. Thanks.